Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
In order to prevent the spread of the virus, we all need to do our part. One of the easiest ways to prevent that is by wearing a mask. In order for a mask to do its job, it needs to cover your nose, your mouth, and your chin. First, you should wash your hands with either sanitizer or soap and water before putting on a mask. Then pick up your mask by one of the ear loops to make sure that there's no tears or stains on the mask. If it is dirty, throw it away immediately. If it's intact, take both loops and put it over your ears like this, and then press down on the bridge of the nose to make sure that it fits and there are no gaps. Once you are done with the mask, please take it off the same way. Both ear loops, pull it away, and put it either in a Ziploc bag or throw it away if it's a surgical mask. If it's a cloth mask, make sure to wash it with soap and water and keep it dry for the next use. Do not put your mask down at your chin or above on your forehead when you are starting to remove it, as that just contaminates the mask. Thank you so much for doing your part to prevent the spread throughout the city.
Thank you so much, Dr. Days. And again, one thing that we didn't have time to talk about during that video is if you have to move your mask, if you feel that it's going down under your nose, you take the mask in the middle of the mask. You stay away from keeping your fingers on your face. Don't let that happen. COVID, this is a time, and you may have heard the term COVID-19 long haulers. This refers to people who have been diagnosed with COVID-19, had a myriad of different symptoms, and technically are recovered. However, there are long-lasting and long-term negative effects and different types of health issues. One of them is issues with the eyes, issues that affect the eyes. That's what we're going to be talking about this evening. We have questions and answers for you about ophthalmology, about some long-term lasting effects of COVID-19 and what we are doing to figure out where we're going from here. Please understand that this is all still relatively new and that there are new studies coming out every single day, so the doctors are going to answer to the best of their ability this evening. As you know, this is a live program, so stay with us and ask some questions of your own. Give us a call at 881-0013. This evening's program is underwritten by Southwest Eye Institute, and we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing the medical students to man your phones, and actually today it's just one. We have Ryan Foresca with us. He's the lone wolf, and he did a great job last time he was on. So Ryan, thank you so much for being here. We appreciate it. And we also want to thank the El Paso County Medical Society for bringing the show to you each and every month. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Good evening. There are long-term effects for COVID-19 for some people, not all, obviously. Again, this is a weird virus. It's still novice, and it's in many ways. There's still a lot of things that we are going to learn, and I joke about this all the time, although it's not a joke, but a decade from now when they write the book about COVID-19, we'll know all the answers that we're trying to find out right now. But Dr. De La Torre, Dr. Javier De La Torre is an ophthalmologist with the Southwest Eye Institute. And what I'd like to do, we also have Dr. Brent Shelley here, and he is an optometrist with the Southwest Eye Institute. But Dr. De La Torre, you've been here a couple of times before, and we've talked about all kinds of different issues. But what I'd like for you to answer this evening is what is an ophthalmologist? And then Dr. Shelley will talk about what an optometrist is and how complementary both of your jobs are within Southwest Eye Institute.
Sure. Thank you for having us again. And so we are colleagues, but in essence, the difference is the training. An ophthalmologist by training goes through a college degree, usually it's a 4-year college degree, then goes through med school and does the minimum of 4 years of med school, and then goes into an ophthalmology training process that it's minimum of 3 years, and depending on the fellowship that you do, can extend past that. And so it trains us to treat both medical and surgical diseases of the eye.
Okay. And then also issues, too, that will affect the eye later on, which is kind of what we're talking about this evening. And Dr. Shelley, optometrist, And complementary to Southwest Eye Institute, what is your all day, every day job? Does that make sense?
Sure. As an optometrist, we too have a 4-year degree, and then go on to a 4-year graduate degree in optometry. The first 2 years optometry school are biomedical sciences. Many of the medical schools in the country now actually have medical school the first 2 years and optometry school combined, whereas optometry goes ahead and diversifies into the eye rather than doing the standard 3rd and 4th year rotations that a medical school does and the residency. As an optometrist, we are trained in primary eye care. Okay, we do, in addition to your standard glasses and contacts, which we do not do at Southwest Eye Institute, we are trained in treatment of eye disease. We don't necessarily do the intense surgical procedures that our ophthalmology colleagues do, but we do some minor procedures. So it's very cooperative. It's a great relationship that we have.
I wanted to start off the show. I was telling Dr. De La Torre, there is I call her Mama Breck, a woman that I have known since I was 17. And I was riding my bike earlier today, went by her house. She goes, "Oh, you're doing the Southwest Eye Institute show tonight." And she just wants to give her thanks, praise, and adoration because she's been wearing contacts since she was 16. She had cataract surgery, and she said, "You know what? And they were able to fix my eyesight too." So it was just so cute. But a thank you from her. And I'm sure from so many patients that you all have had. I want to talk about how COVID has affected your office, at least over the last several, I mean, my gosh, we're into it now a year, right? But we're into it really heavily the last 10-ish, más y menos, months.
Yeah, so like many of our colleagues, we had mandates from national entities that they recommended that we had to stop for a period of time of seeing patients for routine eye care and for elective surgeries. We did continue seeing patients through the pandemic for a period of time, just emergencies, and also we saw inpatient consultations to continue those patients that really needed acute care. But it gave us the chance to stop, put a pause, and rethink our operation. So we've been blessed that through the pandemic, we've been able to reorganize, and we added telemedicine. That's something that we didn't have before, and now we can help patients in a way that it limits the amount of unnecessary visits to the office. We were able to hire more doctors and open more facilities to diversify and have a perfect ratio of patients to doctors to limit the wait times so the patients, when they get there, we see them in an efficient manner. We also added and joined forces with one of the practices here in El Paso of Dr. Louis Alpern and Dr. Tafoya, and now we're very proud to have them under our umbrella and continue the great care that they've had for many decades. So it just gave us a chance to stop, to reorganize, and we've come back stronger. Along the way, unfortunately, it was sad also. We had staff that lost family members, and our hearts that goes to them, including the father of our founder and CEO, Dr. Mark Elman. His father passed away from COVID-19, so it touched us personally, but we're here to do it better as we've come back, and we're excited to be here to share what we've learned during the pandemic and how COVID-19 has affected the eyes.
My condolences to Dr. Elman. He's always been a joy to have on the show, and I'm sure we'll have him on again. On that note, and I know Dr. Shelley, we kind of covered it a little bit too, but on your end too, the office in general, what precautions are being taken to prevent the spread? I know Dr. De La Torre touched base on that, but on your side.
Sure. Well, the first thing is we do adhere to and follow all CDC guidelines. We exceed those guidelines. To prepare for the reopening, we have increased our staff. We actually, the doors are attended. No one enters the building without having been properly screened. I'm sure many people have had the myriad of questions, but no one actually even enters the building now without that. We provide PPE, personal protective gear, for all employees and patients. Every room is sanitized after every single patient. Okay?
That's an excellent thing to say.
Yes.
Okay, yes.
We reevaluated our patient flow. We reorganized our waiting areas, so of course to adhere to social distancing standards, but it allowed us to reevaluate patient flow so there's fewer patients in the building at a time. It actually has reduced patient wait times. It's actually made us more efficient.
Right.
Yes.
And that makes perfect sense too. Like for example, with Zoom meetings, you were talking about telemedicine. I feel like there is an efficiency to, we're here for a purpose, let's get it down, let's get it done. And I think it's wonderful that you guys are doing that. So I have not been to your facility. Is it a one big room, waiting room as you walk in? Describe what your facility looks like as people come in, as patients come in.
Actually, so we have now 3 facilities in El Paso.
That's right.
Yeah,
that's
so
right.
the main one in East El Paso is a big facility that has our surgery center right next to it. And so we've rearranged the waiting area so we have social distancing. And the patient flow, it's one that really there's not at any moment crowding in the waiting areas. We have a central location that we open also this year, and we're excited to also say we're going to be opening in the Northeast El Paso, when we have also an office in Las Cruces, and we're hoping to open a second office in Las Cruces this year. So that's all in part of trying to have a perfect ratio of doctors to patients to limit the waiting areas and the waiting times in our office.
That's great. The conditions that you've noticed during this time, during the pandemic, what conditions are you all treating more, or that you're seeing more of right now?
So you talked about the long haulers, and that's one thing that really surprised us, because when we were first informed about COVID-19, they told us it's an upper respiratory disease and there's going to be manifestations that commonly you see, like pink eye. And so personally, we haven't seen a lot of pink eye related to COVID-19 in the office. Granted that we have a population bias, we haven't seen the very sick patients, but what we've seen is that there's some infections that are happening around the eye that are related not to COVID-19, but to the use of the mask. And so that's something that has really surprised us. And so we're going to touch that in detail. But also we've seen in some patients that had COVID-19 that has presented with changes in their vision, with double vision, with blurry vision, with changes in their visual field as well, which is very early, the information that we've had, but we've been surprised. And so, and we'll also talk about that in detail.
Well, let's start doing that too, because when you were talking about mask, let's physiologically describe what's happening with the mask. Is it because, you know, when you're speaking, air goes up, it goes right into the tear ducts? Is that the type of issue that you're talking about?
Correct, and it's just the fact that we're breathing that humid air upwards. So one fact that a lot of the patients are complaining is that their glasses are getting foggy. And so there's multiple things that can be done to prevent that. And so Dr. Shelley can touch into that.
Okay, Dr. Shelley, it's you now. So we were talking about, because I had a question here too about foggy glasses when wearing a mask, and haven't we all been in that situation? And there are certain times too, and I feel like there's a lot of issues around walking into a war zone, so to speak. I'll put the shield on too, and talk about fogginess everywhere. So let's talk a little bit about that.
Sure. You know, it can certainly be frustrating. You're sitting there and you're trying to read or write or something, or respond to a text, and autocorrect gets it all wrong.
Exactly. I've got two languages on my phone, so yeah, it does it all the time. Yeah.
So there are commercially available sprays that you can use to treat current glasses. A lot of the optical manufacturers have actually come out with an anti-fog coating, and as a little personal info on me, I've been a scuba diver for 30 years.
I was just going to say, is that the same spray I put on my goggles for scuba diving? Interesting.
Well, I'm a scuba instructor and a master scuba diver, and for years I use a 5-to-1 ratio of water to baby shampoo. When you're a scuba diver, you don't get to rinse your mask out.
Right.
That is what I use personally on my glasses and examination lenses. A little spurt of a 5-to-1 ratio of baby shampoo to water, and you're good to go, and you clean your glasses at the same time.
I love that. I'm going to start using that. Okay, so I'll use that a couple of times too.
And there's other patients that have used a very simple trick of just applying a piece of tape at the tip of their mask, and that will avoid the air flowing upwards. And some patients have benefit that when we do surgeries, like the patient that you talked about, where we do cataract surgery, where we do LASIK surgery, we're able to decrease the dependency of the glasses and therefore get rid of the
Bingo.
Of the fogginess of the glasses with surgery. So there's patients that actually have come to us asking for LASIK surgery, for cataract surgery, because they just want to get rid of the fogginess of the glasses.
Wow. Very, yeah, 'cause this is not going away for quite some time. Dr. Shelley, styes, and chalazions?
Chalazions.
Chalazions.
Yes,
I was like, man,
yes.
almost sounded like an Italian dish. I wasn't quite sure. So let's talk about, so I know that my kids had styes before, but chalazions, I don't know. What are the differences between the two?
Okay, so a stye is an active infection of an oil gland in the eyelid. I like to explain to my patients, it's kind of like a pimple in your eyelids, okay?
Like where their hairs come out? Is that where the
yes,
oil
yes,
glands
in
are?
that general area, yes
Okay,
ma'am.
okay.
And it's an active acute inflammation, okay? Whereas a stye is where the inflammation has more died off, the bacteria aren't necessarily growing and reproducing. A stye is very tender to the touch, it's sore, you don't like to touch it and rub it.
Looks like it hurts, yeah.
Yes. A chalazion is less tender to the touch, okay, and is more of a long-term necrotic dead bacteria issue.
Oh, wow. Okay, so describe what that might look like.
Some people will complain that, you know, I've had this bump on my eyelid for 2 or 3 months, or people will say, you know, I had a stye a few weeks ago, and I tried some over-the-counter stye remover, and you know, it feels better, but I still have this bump. So it went from being a stye to being a chalazion.
Okay, so a chalazion, to continue with that, is there a way to, does that go away on its own? Does that require treatment?
You know, there are treatments, and I'll yield that to Dr. Delatorre.
Okay, great. Before I do that, just my natural question, pink eye. Because that's something, you get pink eye in school, it's like everybody's got to stay home, it's like lice, whatever it is. So I know it's not on here, I get it. But talk about pink eye really quick, just because that's another common issue.
Sure. Pink eye is a generic term for a condition called conjunctivitis. There are a variety of different causes, and it depends whether it's a bacterial cause or it's a viral cause. That in and of itself is the real determinant on how contagious you are.
Okay.
Yeah. You can actually have the common cold and then get a flaring pink eye thereafter, okay? And you can also have a bacterial infection that clears up within a day or two with just antibiotics. Viral pink eye, conjunctivitis, due to the cold, you know, it takes a week or 2 to resolve, whereas a bacterial conjunctivitis will clear up very quickly.
Okay, so it's kind of still like the, so
Yeah,
you can't,
definitely
depending
see
on, viral versus
an eye
bacterial.
care professional to differentiate the diagnosis. on
Okay,
that.
and if I could, because we're on this subject too, when a parent is looking at a child with pink eye, because I remember with my poor kid, we were on vacation, we had to find a doctor. Describe what pink eye looks like versus a stye.
Yes. So pink eye will cause the white of the eye to be red. And the child will generally complain that they've got crusting on their eyelashes, the eye tends to burn, it feels irritated, they've got a lot of mattering. Whereas a stye, it's more to the eyelid itself being red, swollen, and tender to the touch.
Okay.
Yeah.
Perfectly described. And I know, Dr. Delatorre, I just stole that away from you. The treating of the styles.
No, but I want to touch on something
Yes.
that Dr. Shelley mentioned, and he made a great point in explaining how a stye is like a pimple in the eyelid. And I was talking to some of my colleagues that are dermatologists here in El Paso, Dr. Guevara, Dr. Osanik, and they've noticed the same issue with the mask use, and they're calling it actually mask knee. So acne created by the mask. And so it's a general problem.
Makes perfect sense to me.
So it's in general, it is an oil gland that gets blocked. And when an oil gland gets blocked, bacteria will try to invade it and cause an infection. Same thing in the skin, same thing in the eyelid. And so styes, as Dr. Shelley explained, is an infection in the eyelid, and we tend to treat it with antibiotics, a combination of oral and topical antibiotics. We tend to prefer ointments rather than eye drops. Eye drops are mainly for pink eye, versus when it's an eyelid infection, we tend to treat it with ointments because it penetrates to the skin. The eye drop will penetrate into the eyeball itself. So
So
ointments.
you're talking about ointment, that's kind of got the consistency of Vaseline.
Correct.
So I'm just trying to
but it's
differentiate
designed,
between-
but it's designed to be used around the eye, so if
Right.
it gets in the eye, it doesn't sting.
Gotcha.
And then antibiotic pills, and we like to use warm compresses to massage that area. And the warm massages attracts vasodilation and healing power of your body to that area to get rid of that infection. We've seen a dramatic increase in the frequency of styes and chalazions since the pandemic started.
Interesting.
So this has become like the second pandemic. We're seeing about 3 to 5 new patients with styes and chalazions daily. And there's been an increase also in the frequency of how many surgeries we do for the chalazions, because the styes we tend to treat with medical treatment and they tend to get better. But the stye that never drains becomes a chalazion, as Dr. Shelley explained. And those we tend to do more surgical procedure. When the patients develop a chalazion, we bring them to the clinic, we numb the eyelid, and we do a procedure where we drain the chalazion from the inside of the eyelid so there's no visible scar outside. And they wear a patch for a day and they go home and use the antibiotic ointment to help them heal, and tends within a week to get better. But this, we've seen a dramatic increase. We've seen, compared to 2018, 28% more cases
My goodness.
that we
Okay.
did in 2020, and 22% more compared to 2019. So there's definitely a correlation. And again, we're not anti-maskers. We do believe
Oh, yeah. So
that
that's
we
why I'm
have to
asking you
use the mask.
prevention.
We have
But,
to use the
yeah.
mask, but there are ways to be able to safely use the mask, but also prevent styes and chalazions.
Okay, and that's where you come in, prevention man. So we talked a little bit about, so is the cleaning of the mask, and that's something too, like I'm wearing a cloth mask. I've got several of these exact same masks, but is it right to say you have to treat your mask like you're cleaning, like you treat your underwear? You clean your underwear every day, right? If you only have one pair, you're gonna clean your underwear every day. Same thing with the mask if you guys have a cloth mask or a permanent mask that you have around. It's different with you all if you've got disposable masks, but I just wanted to say that just in general, because we're going to be in mask mode for a good year,
Yes,
around
easily.
the globe. So other prevention that you might be able to think of.
Well, certainly cleaning your mask, like your mom would say, I don't want you to have an auto accident in dirty underwear.
Exactly.
Make sure you definitely are washing your mask, hot water every day. Have 2 or 3 masks. As a matter of fact, like we said, the data is always changing. What I say today may be different next week. But even just yesterday, they came out saying that maybe 2 masks
Right.
is the way to
Standard,
go.
the new standard,
So
yeah.
definitely clean mask on a constant basis. Yeah.
And when
Yes,
the
Dr. Delatorre?
patients have been using the mask, and again, we see with the foggy glasses that air is coming upwards, we believe that that air is bringing bacteria to the eyelids. After a day where you've been using the mask, water and soap, we recommend baby shampoo that doesn't sting, and we can clean the lash as well. They also sell commercially available lid scrubs that have a shampoo that doesn't sting. And we can just scrub our lashes well to remove the bacteria that have accumulated throughout the day and prevent the styes and the chalazions in that way.
Interesting. Okay. I think we covered most of that. I'd like to talk about, and I just thought this question was interesting. This is a question that you all provided, which I thought was kind of cool. Dr. Delatorre, the types of problems that you're finding post-COVID, firefighters who have had COVID, now they're technically again recovered, like we talked about beginning the show. Firefighters specifically, you were talking about. What's going on
so
there?
it's a very interesting story. Talking about the long haulers, so we have a doctor that has worked with our office, Dr. Nance, and a trusted doctor. He already retired, and he put us in contact.
I know Dr. Nance from a
yes.
whole life ago.
Yeah, so-
Goodness gracious, yes.
So
okay.
great guy. And so he put us in contact with an occupational therapist that has been helping firefighters here in El Paso recover from COVID. And she noticed a pattern of these firefighters complaining to her about vision changes. And it was really interesting. So we invited these firefighters to come to our office, and we did a full examination. Dr. Shelley was the leader there. And we had a protocol on how to examine them and how to test their eyes. And we started to notice a pattern of these patients having blurry vision, having double vision, having also changes in their peripheral vision. And we found it very curious. We're not saying that it's only isolated to firefighters. That's all our experience in how these patients came to us from these occupational therapists that noticed this trend. And so we are in the early stages of collecting data, and we're sending these firefighters to get more testing to see what correlation we can find and where the problem is. But Dr. Shelley has taken the lead, so he has more details about that.
So I'm going to ask you about that. And again, what this book 10 years from now will reveal. That's interesting to me. Question here, objectively verifiable, right? And that's one of the questions too, the complaints. And again, we're looking at firefighters now and thoughts of who might come up with these issues in the future. I don't know. Absolutely.
So first, let me say it's been a thrill, if thrill is the proper, appropriate word. I've been honored to work with these firefighters. And we've got some really interesting data. Some of the tests we can do involve measuring eye alignment, measuring peripheral vision, measuring visual acuity. These are all objectively verifiable conditions, whereas pain is always a subjective thing. We take people at their word, we have grading scales, but it's very subjective. But the verifiable objective information that we've obtained is very interesting.
And what, I know it's just a guessing process right now, why might you think, is it firefighters? I mean, is it, it's just curious to me.
Firefighters are the subjects of the study. They were directed to us.
Okay, so it's not necessarily their occupation per se.
It's not every post-COVID patient that comes in the office.
Okay.
It is this subset of patients that are in the office that we're corroborating with other providers on.
I get you. Yeah. Okay, because in my head I'm thinking, would they have had to have been in the fire, have smoke? I mean, what situation?
Oh no, it's not that type of thing.
I get it. Just happens to be that study group that you're looking at. The results of the finding, Dr. Shelley, we were just talking about that too. And so I have, I've got a lot of the questions that we burned through really quick, but here's a great question from the audience that I want to ask from Ryan. Thank you, Ryan, for sending this away. I'm reading this cold. Have you seen a trend in diabetics or those with macular degeneration being more affected by long-term eye symptoms after COVID-19? Question from the audience. And again, I will stress this too, this is all new. I mean, we've been in this for 10 real months, and so a lot of this stuff is brand new, so I just want to give both you guys a disclaimer, even though we have that beginning of the show. So we're going to do the best that we can to answer this question. Would you like me to read it again?
No, I got it, yeah.
Okay.
So I can tell you that diabetes being a pre-existing condition and patients with diabetic retinopathy, which is a manifestation of diabetes in the eyes, it would make sense for those patients to be at higher risk of having complications. We personally, we don't treat diabetic retinopathy to the level that's more of a retina specialist. So we haven't seen a lot of patients with, of that subset of population to really be able to gather that data and answer that question accurately. But there are retina specialists in town that that's their bread and butter. They dedicate themselves to diabetes and diabetes in the eyes.
Okay. On that same note, and I'm just thinking cataracts, and I know we're deviating from here now, but the idea of cataracts, and it may be or maybe not related to COVID, but because we have you guys on the air, and because we have people in the audience that they're going to have cataracts whether or not COVID's around or not, I would like to talk about what cataracts are, like what physiologically is happening to the lenses in your eye when someone starts to develop cataracts. And then I'd like with you on that answer, talk about the stages. Like some people don't know that their eyes are cataract-y until it's a good point, right?
Yeah. So we have a natural lens that God placed inside the eye. And that lens over time starts to go through the natural aging changes that at first makes it not to be as flexible. And that usually starts around age 45 to 55. Where we start to develop the need for reading glasses. And then later on in life, that lens starts to also opacify and get cloudy. And that starts to not allow the light to go through the eye and be able to focus properly in the retina, the back of the eye. So that's what we call a cataract. So when the lens gets cloudy, and gets stiff and doesn't help us focus well.
Okay.
And so we have a grading system, goes through 1 through 4. And so 4 is a mature cataract that in theory the patient has significant loss of vision. 1 would be a cataract that is in the early stages that the patient still with glasses or contacts can see well and function well. And so we want to emphasize that in terms of cataract surgery, no longer with the modern surgery that we do nowadays, there's reason to wait until a cataract gets to a 4 to do cataract surgery.
Okay.
And so now we've noticed that with the COVID pandemic, a lot of the patients that are in the cataract age, they wanted to postpone their routine eye care that includes regular exams for cataracts and cataract surgery. And so we want to encourage those patients to come back and to have their eyes examined, that we have taken all the precautions to ensure their safety in the office, because you don't want to wait on a cataract to continue to ripen to then do the surgery. And so we're hoping that in 2021 we can capture those patients that decided to postpone their care during 2020 and make them feel welcome and safe in our facilities.
So here's my question too. Sometimes people, you were talking about ripe. That was one of my favorite questions from way back when. What does it mean when a cataract is ripe? You have to have it ripe before removing, but you're talking about it doesn't have to be ripe. But when a patient, because sometimes your vision can start getting worse, but because it's happening so gradually, you don't know it. When do you think, how's this question? When one might know when it's time to go? Should I talk to Shelley about that? So Dr. Shelley, again, and I remember this happened with my grandmother, which is why we were talking before the show. My grandmother was 80 when she had a new lens put in her eye. It was back in Germany, but it was 30 years ago. So I'm thinking, gosh, the surgeries from now versus then. But she said she waited too long. She didn't want to have the surgery, and we were bringing her to America to live with us here, so she wanted to have everything done there. But in general, how do you know when it's time? How do you know when you think you have cataracts? Does somebody need to tell you your eyes look cloudy? Do you see that you are having a hard time seeing? And I'm talking about people who are not getting the yearly eye exams, which they should, is something we should say on this show too.
Definitely they should be getting their annual exams. But the complaint that someone will notice that they're developing cataracts is they'll have glare at night when driving, or they'll have a ring around headlights or street lights, or like last night was a beautiful full moon. People will see 2 moons superimposed over one another. Reading the ticker on the news at the bottom of the TV or subtitles, they'll notice problems with that. Inverting letters, difficulty doing tasks around the house without having bright light. You know, they have to put a really bright light on to be able to read and stuff like that. Basically, they'll be going along, they'll start noticing their vision changing, and then so they do seek out care, and that's when they find out, oh, I have cataracts, I don't need just a new pair of glasses, because it's so slow and insidious. It really is, like you mentioned.
And one way that patients can know that it's the cataract affecting their vision is that when they go for that annual exam with their optometrist and they're given new glasses, and then they put the new glasses and they don't see a wow effect of that new glass that helped them see better, that's the cataract, because the problem is inside the eye. So it doesn't matter how new and fancy are the glasses outside, the problem is inside the eye. So that's a way that the patient can also know. New glasses don't make a big change in their vision.
Right. So here's my science question that I want to ask you. So what exactly are you doing physiologically to the eye during a cataract surgery? Because we were talking about this a little bit before the show. When God gives you that lens and we take that lens away, we got to give it the lens back.
Right.
Could you kind of describe to our audience who might be in that world of, oh, should I have cataract surgery? Should I not? Describe how the surgery is.
So cataract surgery is an outpatient procedure that is done under local anesthesia and sedation. And in our facility, we have mastered the cataract surgery to a level that the patient's satisfaction is really high. Typically, we place a pill under their tongue that melts, and that gives them enough sedation. We don't have to start any IV. And we do eye drops that numb the eye. The patient is taken to the operating room, and we just have a cover just for the area of the eye. But they're breathing and they're interacting with the surgeon. They're talking to the surgeon. We do very small incisions over the cornea, and we enter the eye and we open the sac that holds the cataract. Think about it as a grape, and we're gonna remove the skin of the grape. And that gives us access to the inside contents.
Okay.
We're going to use a machine that is called an ultrasound machine, and we're gonna eat up the inside contents, but we're gonna leave that sac. Like the skin of the grape is left behind. And in that same skin, we're gonna place the new lens that goes inside the eye. There's multiple lenses in the US market that can be used, and we customize the lens to the patient. So now it's not cookie cutter, everybody gets the same. We have ways to customize the vision for the patient so they can achieve the best vision possible and the less dependent on glasses after cataract surgery.
That's fascinating to me. So here's another question. To stay awake during the surgery, the sedation you said that they have, is that a necessity? Is that so that there can be communication with the doctor as the surgery is going on, or is that more of a comfort level?
It's for comfort.
Okay,
And so
okay.
there are patients that request no anesthesia.
Oh my God.
Yeah. So we encourage patients to have the anesthesia so they're more comfortable during
Right.
the procedure. I would say that most of the patients, they do like the anesthesia we provide.
Right.
And for the second eye, they request the same.
Okay.
But
And do you have people that ask to be put out completely?
we have patients that have requested that. We don't provide those services because
Okay.
we feel that the risk of doing that outweigh the benefits. Cataract surgery in our surgeon's hands is about 8 to 10 minute procedure. So it's really not
okay.
worth the risk of putting somebody under anesthesia for such a small
Okay.
period of time. But there are some patients that, because they have disabilities, that they cannot cooperate with the surgeon, that they do have to be put under anesthesia. And we refer those patients to other colleagues that we have in El Paso that do a great job with sedation.
So when I need to have this done many, many years from now, you need to make me super loopy. That's all I'm asking. I need to be super, super loopy. Dr. Shelley, I have a question here about focusing and eye alignment, et cetera, et cetera. So I know that's part of your specialty too. So if we could talk about just eye alignments and focusings. I know we're kind of deviating from cataracts here, but it's a question that was interesting me here before the show.
Okay. So what this question deals with is some of the findings we're having with our COVID firefighters, okay? And the results have been really interesting, as I alluded to earlier. 91% of our patients in the COVID study. I'm going to refrain from saying firefighter study so we don't.
Okay, yeah, that helps because I keep thinking it's because of their occupation, but yeah.
91% of our patients in that study complain of eye pain.
Eye pain.
Eye pain.
Okay.
And 66% have a verifiable change in their peripheral vision.
Interesting. That's a big percentage.
It is. It was an astounding percentage when I was crunching the numbers and doing the test.
Okay.
And then for the eye alignment and focusing, 54% have problems focusing. All but one.
And this is all post-COVID.
Yes.
This is
this
they
is
had
all-
COVID, they're recovered from COVID. This is now some of the
Exactly.
long-haul issues. Okay.
Correct. Their distance vision is still perfect. They all have perfect distance vision. What happens is when we read, our eyes converge. That means our eyes point in, okay? So we look
Right.
at something up close.
Right.
54% of our patients, and there's actually only one of them that's different, have had an eye that points out. We have one patient where his eye crossed in. Okay?
Interesting.
Yes.
Okay.
So I have theoretical reasons on what that is, but I'm not even going to put those out there because it's all in theory, and in theory,
Yeah.
communism works.
You know,
So-
we have a disclaimer at the beginning, at the end of the show, because everything's almost theory
Yeah.
right now when it comes to, again, long haulers. It's a terrible word to use, but that's what they're using, and that's what people know about it. But would you feel comfortable throwing out a theory and disclaiming it as a theory as to why that might be a case? And if not, I completely respect that.
Honestly, Yeah, I do.
Okay, let's do.
I do.
Okay.
And it all ties in with the visual field.
Okay.
So as I mentioned, 66% of our patients have a verifiable visual field. Of that 66%, 2/3 have a visual field loss at the top of their vision, 1/3 at the bottom of your vision. Why does that matter? Because the neurons or the nerves that run from the eye to the vision cortex of the brain run a very distinct pattern through various parts of the brain. Superior visual field, stuff we see up here, is processed in our temporal lobe, which is where memory functions are at.
Okay.
Bottom visual field is our parietal lobe, where proprioception, sense, touch, knowing where I am in 3 dimensions is at, okay? Also, by the parietal lobe, at the brainstem is an area called the corpora quadrigemini. This is where vision and hearing interconnect to allow us 3D. When you hear something, you know where it's at. That's processed in the corpora quadrigemini. And I hypothesize that somewhere in that area where there's been something neurological, but it's only in theory. Disclaimer.
So we're talking about the eyes, but really in essence, the theory, and I respect that, is kind of a brain issue
Oh,
more
absolutely.
than an ocular issue.
The
It's all
visual
the
field.
communication between the ocular.
Yes,
Okay.
the visual field is actually a wonderful neurological test. It's used for migraines, it's used for strokes, it's used for myriad issues other than just like glaucoma, which a lot of people think of peripheral vision and glaucoma.
Okay.
So what we've
Yes,
done
Dr.
is
De La Torre?
send these patients to get MRIs to see if we can identify those areas that Dr. Shelley have mentioned in the brain and see if we can point at where the issue has been and see if we can make the correlation of the eye findings that we're finding with the MRI findings and if there's any pathology that was created post-COVID. But again, this is all theoretical right now.
No, I mean, this is great. So how long have you been sort of kind of studying this? Was this brought to you several months ago?
Yeah, several months
Okay.
ago, we were
Okay.
approached by Dr. Nance and by his friend occupational therapist, and so we got Dr. Shelley involved, and so we've been in it for about a couple of months now, and it's very interesting. We're still in the very early stages, but this is the things like you say that in the future we'll look back and then
Right.
try to put the pieces of the puzzle together. But right now, this is just too early to
You
know.
have to make sure to get a recording of this program.
Okay.
Okay, so that 8.5 years from now, you
When
can
we
go,
write the
"Hey,
book."
remember that's kind of what we thought it was, and it turned out to be the case. So I think that's fascinating. In fact, it'd be interesting if people see the show, if there's another occupation, I don't know, when I say occupation, because it's an occupation therapist that brought this to you, right?
Yes,
Or the
correct.
whole idea of it, but just the interestingness of itself, are there other people that have different visual issues? You said earlier that there was complaint of the eyes hurting. Now, to me, when I think my eyes hurt, that's when I feel like I'm getting a headache behind my eyes. And I don't know if it's so much my eyes or it's one of those ocular, I call it an ocular headache. It's not what it is. But what was that complaint? Like, how were their eyes hurting? Does that make sense, the question?
Yeah, it sure does. Pain behind the eyes. And I specifically ask them when they complain of eye pain, are you talking about the front of the eye, the eyelid? I do try to localize it. And invariably, it's pain behind the eyes.
Like a pressury pain. I don't know why I'm so curious about
Yeah,
this. But,
a dull, constant ache. Yes, ma'am.
okay.
But
Yes,
we
Dr. De La
we
Torre.
want to use this as a chance to open it to the public to help us.
Bingo, that's
Yeah.
why I want to bring this
If
up.
there's more patients out there that are having the same issues, to please call our office, 915-267-2020, and make an appointment so we can help them figure this out. And they will help us also with gathering more data so we can then be able to make informed decisions and conclusions that we can then learn from. But right now, it's very early. We have just a very small sample of patients. But I'm pretty sure that there's people out there that are hearing us that are relating to this, and
Right.
we want to welcome them to come to our office and call our office to make an appointment.
Okay. And I just, again, love the idea that it's like a case study, so to
Correct.
speak, and or even a clinical trial if you get to a point of trying to treat what these things might be. At that point, Dr. Shelley, right now you're just studying what it is, but there's really not a a way of treating it that we know of yet. Again, it's too early in the stages.
That's correct.
We're trying to put it all to that point. So again, if you've got some of those issues, if you're post-COVID in recovery and or recovered, and you're having some of these issues, again, Southwest Eye Institute, call them and just kind of let them know what's going on, and this could be something that they can study you too. That number is 267-2020. Again, since I have you guys here, we got another question here from the audience. Give me just a second, I'm reading this cold. Question from the audience, a 67-year-old female who is overall healthy, but every now and again will see stars and twinkling in my peripheral vision. We were talking about this, Dr. Shelley was talking about that. I don't get dizzy, but I want to know if there's some kind of concern about this. Actually, I don't know which one of us. We were talking about what the signs of cataracts could be. Would this be a classic?
This is something different. So
Okay.
when the patient see lights in their vision, there's two things that come in mind. Number one, the retina, which is the film of our camera, if it's stimulated by pulling and tugging on it, it will trigger flashes of light, especially in the periphery of the vision. So when a patient sees new flashes of light, we always want to have them come in so we can examine the retina, make sure that the retina has not been pulled to the point where it breaks and tears. The other thing that can, in a healthy patient, cause those changes in the peripheral vision, it's actually retinal migraines. There are some patients that have, because the retina is made out of neurons and axons, they can have like a migraine, but in the retina. And the way that the migraine will manifest would be with changes of light and in the peripheral vision. So that's something that it could be one or the other. We would have to examine the patient to know. But those are the two most common reasons why a patient would see lights in their vision.
So here's just a Catherine Berg question. And yes, I have blue eyes. People are like, you're so sensitive to light because your eyes are blue. I'm like, yeah, I don't buy it really. Why is it that some people are so photosensitive and other people's aren't? I mean, I remember my daughter, you know, I used to call her the vampire because if sun shined in her eyes, she'd like, ah! What is that condition? Why does that happen? I'm just asking whichever one of you wants to take it. Dr.
Sure.
Shelley?
Yeah.
It's your turn.
So you answered your own question with the blue eyes.
Oh, so it really is. So I mean.
So what happens is there is a pigment inside the eye called the melanin, or called melanin. And it's the level of melanin that dictates light sensitivity. I have green eyes, you have blue, Dr. Delatorre has brown. Believe it or not, all three of us have black pigment on our iris. And it's the level of pigment that actually gives us the light color that we reflect back to people when looking at our eyes. So it's the short answer is the amount of pigment in the eye.
Pigment in the eyes.
But
Wow.
also the pupil size that you have. So there are some patients that they tend to have larger pupils.
Yeah, it's my kid,
Therefore,
that's my
they
daughter, yeah.
allow more light into the eye, and so that can trigger the light sensitivity. So the amount of pigment, like Dr. Shelley said, and the
Right.
pupil size will determine the light sensitivity.
How interesting. Pupil size makes sense to me as well. So my daughter has blue eyes, my son has brown eyes. He's never complained a day in his life, but my daughter has big old honking pupils, and we've always kind of made fun of her eyes. She's got huge eyes anyway, but she really, really had a problem when she was, I mean, from infant until 3 or 4, we're like, we're just gonna put sunglasses on you. Fascinating. Question here from the audience. Since October, it doesn't give me an age or any information other than that, but the question from the audience is, since October, I've had mucus in my left eye. Putting eye drops helps dissolve it, but it comes back. Who should I see for this? So we were talking about all the different, the styes and the pink eye, et cetera. Who wants to take that one? Dr. Shelley. So mucus in the eye, in one eye, but since October.
Yep.
Goodness.
You know, off the cuff, I would guess that this patient has a plugged drain duct of the eye. Our tears run from our eyebrow across our eye and down into our sinuses. There's a little duct at the corner from the eye to the nose. And that's why our nose runs when we cry, because the increased tears going down there. I suspect that this person has a blocked tear duct, drain duct, and that's what's causing this.
And could they come to your office? Is
Absolutely,
this
they
something come to
could.
your
We get
office
them
too?
cleared up.
Okay. Question here from the audience. What is macular edema? And is it reversible? Question from the audience.
Yeah, so macular edema is when, so the area of the retina, which is the back of the eye, the film of the camera, that got designed to see the sharpest is called the macula. And the macula, when it absorbs water, that's called macular edema. The two most common reasons for that to happen is diabetes and macular degeneration. And so those are the two most common reasons why the macula would develop swelling, and that swelling would limit the amount of vision of the eye. That area is not designed to have water, so it will distort the vision. And so macular degeneration, not only there's edema, but there's bleeding in the macula. And again, this is a disease that tends to be treated by a retina specialist. And diabetic retinopathy, in, again, early stages, same thing, you prevent it by just keeping your sugars under control, but when it gets to the point where you develop macular edema, you need help, and we refer the patients to our retina specialist.
Okay, so it's not reversible, but it is treatable.
It is treatable,
Okay.
but it can be reversible. It can be
Okay.
with appropriate and timely treatment. So if the patient has macular edema for years, very difficult to remove that. But if it's something that is treated over fairly promptly, we can reverse it.
Okay. We have about 6 minutes left in the show. I didn't stop as early as I thought I would because things were just going so well. So Dr. Shelley, is there anything that we have not covered this evening that you'd like to talk about? And Dr. De La Torre, I'll ask you the same thing in a moment.
Well, definitely the importance of annual comprehensive ophthalmic examinations cannot be understated. Or I should say cannot be overstated. Overstated, I apologize. The eye and vision is our universal sense. It is the most valued sense that we have, and the changes in the eye can be very slow and insidious. And here in El Paso, with our large Hispanic population, there is an eye disease called glaucoma, okay? People don't know they have glaucoma. It can only be detected during a comprehensive ophthalmic examination. And left untreated, glaucoma can cause severe vision loss, leading to blindness. So definitely,
this is pressure in the eyes, right? The eye pressure.
Right. It's generally thought of pressure, but it's actually more broad than that. But yes.
Okay.
Yes.
I just thought I'd throw that out there really quick, because
Absolutely.
when they're
Thank you.
checking that in the office, that's what they're checking for. Dr. De La Torre, just because we're running out of time, anything that you'd like to bring across that we haven't?
I just want to emphasize that we're open for business, that we've taken all the precautions for patients feel safe, and that we've implemented telemedicine. A lot of these patients that we've been seeing with the styes and the chelation related to the mask, the initial visit we're doing over the phone. And we're helping them, we're trying to guide treatment without actually having the patient come into the office, and initiate treatment over the phone, and then bring the patients that really need to come in. A lot of these mask-related infections that we've encountered, we've been able to treat over the phone and save time and money to the patient. So we want to let them know that we're open for the business, that via telemedicine or in the clinic, we can help them out, and that will make sure that they're safe once they're visiting our facilities.
Yeah, at the end of the day, don't delay your medical care, because again, there are very few safer places than being in a medical type of a situation. It's your office. In the hospital, believe it or not, you know, some people are like, oh, I don't want to do that. But if you've got an issue, take care of it. We've had cardiologists on that people did not take care of their heart issues and unfortunately succumbed to that. I wanted to say a couple of websites and telephone numbers really quick. If you have not yet registered for the COVID vaccine, it doesn't matter what phase you're in. I just registered 2 days ago. I'm phase 4. I'm like the last of the last of the last that's allowed to get it. I'm 53. I have no underlying conditions, but at least I know I'm registered. EP, think of El Paso, epcovidvaccine.com is where to go. On that opening page, you will see pre-register. On that very top right-hand corner, do that so that when your turn comes, you're already registered and you're ready to get your vaccine. So let me repeat that. EP, the word COVID, COVID, the word vaccine, vaccine.com. Go there to pre-register. And I have to give a huge high five to El Paso, El Paso County, you know, Texas as well, but El Paso has been doing very, very good at the distribution of the vaccines. I know that there's, you know, every night on the news you hear all this, and it's true. I mean, we've got a lot of issues globally as far as disseminating the vaccine, but El Paso had a plan in place months ago, and of all of the areas, El Paso is doing really well in that area. If you are not a web person or a website person, telephone number to call, 915-212-1032. Again, 915-212-1032. And the website again, covidvaccine.com is what it is. I want to say thank you so much. And now I feel like I have too much time. I'm going to tap dance for a little bit. We have 2 minutes? God, we have 2 more minutes. What do you want to say?
Well, I want to thank all our staff that
there you go. Perfect.
That has been so compliant with wearing their PPE and helping us keep the facilities clean and sacrificing themselves going to work. And so we want to truly thank them for that sacrifice. And most of them already, fortunately, has gotten the vaccine. So you're right, El Paso County has provided that. And so we're very proud of all of them, so we want to thank them.
Nice. And keep wearing your masks. I know that help is on the way. It is. But we still have to be very cognizant of keeping the masks on, social distancing. I know everybody's tired of it. This is a medical show, so if you're watching this and you're rolling your eyes because you're tired of people telling you, just keep doing it for a while and do register for the vaccine. That's us as a medical entity saying that it matters. So register for the vaccine. Once you get the vaccine, that's when we can start getting our herd immunity into place. I know that's a whole nother topic for another 15,000 shows. But for the most part right now, there are 2 vaccines that are approved that you will have 2 doses for. They're looking at another vaccine that we'll only have 1 dose for, but epcovidvaccine.com. Hey, Ryan, our first-year student, I want to say again to Ryan Floresca, who has been really, oh, look at you, you're all smiley and happy. He's done a great job. So what he does is sends me all the questions via my text. But high five to you, my friend. You're doing a great job, and we appreciate that very much. And also a big thank you to the El Paso County Medical Society for bringing the show to you every month, and actually oftentimes more than that, and the Southwest Eye Institute. You've been watching the El Paso Physician. I'm Catherine Berg. Stay safe. Keep your mask on. Good night.